So the removal of complete debris from the pulp tissue or pulp canal, and if it contains microbes because of being necrotic, or if it is a vital tissue that needs to be removed, and whatever debris is produced and the microbial toxins that are produced, if until unless they are removed completely, the endodontic success cannot be guaranteed. But yes, effective removal is important, and irrigation plays an important part in removal of all that debris from the pulp canal space. So let me introduce myself. I'm Dr. Vaibhav. I've done my graduation from a very prestigious MSMI Dental College in Bangalore, India. My master's in endodontics was granted to me in 2011 from Vaibhav University. And currently I'm running a practice in New Delhi, NCR since 2015. I wish to share a disclaimer with you all. I am a key opinion leader with Dentsply Sirona Endodontics, and the presentation may contain certain material that can have copyrights. So the learning objective for today's webinar is why should we do irrigation, or what are the goals of irrigation? What are the desired functions of an irrigating solution that we use daily? The irrigating solutions that are currently used in endodontic practices, the interactions between irrigation material or irrigating solutions, and the combination products that are commercially available for higher efficacy of irrigation, the challenges of irrigation that we usually face during the treatment, and what are the latest irrigation devices and techniques. So it's just a current update to the entire topic. So while doing root canal treatment, what we see is there are a lot of pulp material or pulp tissue that is removed, and the sealer goes into the apical foramens and produces apical puffs, and the sealer extrusion is seen. So usually an endodontist gets happy when they see this kind of apical extrusion of sealers, because it somehow it ensures that the canal was completely clean. But what happens is, even if there is some sort of extrusion is there, even if a little amount of necrotic tissue is available, the success cannot be guaranteed. So what happens? There are certain areas that are not touched even when the best of the instruments are used and in the best of the techniques, and even the masters, when they use it, they definitely cannot touch certain areas. What are these areas? These are the difficult parts of the canal anatomy. They are called as fins, isthmuses, apical deltas, lateral canals, and anastomoses. These are the ramifications that are available and given by the Mother Nature. They should be seen or treated because they can actually contain the debris that is produced during the instrumentation, or these are the areas where already bacterial toxins are present or certain amount of pulpal tissue is left. So why they should be removed? If they're not removed, they will definitely cause problems in the actual treatment outcome. So let us see. In this photograph, you can see there is certain amount of necrotic tissue that is available even after the obturation is over. So what happens is, it does not allow the obturation material to adapt completely into the canal walls. If it happens, it will still have certain amount of microbes available, or their toxins. The apical ramifications and isthmuses and fins, they are uncleaned spaces. So what happens is they harbor more bacteria. What can happen? Why we need to remove them even after such good root canal treatment is over? We need to remove them because all these ramifications, if the bacteria is still there in them, they will cause persistent inflammation. Periradicular inflammation will be definitely available. If it is there, it will definitely lead to more failure of the treatment, or what we can say, it reduces the prognosis of the entire treatment. So what happens when we remove the necrotic tissue? It provides us more space for the obturating material, and it ensures that the canal was much more cleaner. So the chances of success improves. So what are the goals of irrigation? Why we should do irrigation? Irrigation should be done because it removes all the microbes and the tissue remnants and the dentinal chips from there. What an irrigant does it prevents the packing of hard tissue and the soft tissue that is produced during instrumentation and in the apical 1/3. Also, it helps in avoiding any debris that is contaminated to go beyond the apex. So if contaminated material is going beyond the apex, definitely it will cause pain to the patient. So why we should use more irrigations? Because they dissolve a lot of organic and inorganic tissue in the root canal. Antimicrobial property is one of the most sought after properties of an irrigant solution, because if they're antimicrobial, they will definitely kill the present bacteria and the yeast when they come in contact with them. So what are the desired functions? The irrigant should have a flushing action or a washing action, and it should remove the debris that is produced. It should also reduce the friction between the instrument and the canal walls during the preparation phase. It should also facilitate the deeper removal of dentin. That means it should become the dentin should become softer when it comes in touch with that, and deeper sections of the dentin can be removed during instrumentation. That it should dissolve the organic matter like dentinal collagen, pulp tissue, and biofilm. It should kill bacteria and the yeast that are also present in the biofilm if it is present. It should not irritate or damage the vital periapical tissues. It should not be caustic in nature or have any cytotoxic effects. One of the primary things irrigant solutions are now seen is they should not weaken the tooth structures, because the whole purpose of the endodontic treatment is to save the tooth, not to weaken the tooth. So here I am enumerating very popular irrigating solutions, because the time is limited and we need to discuss a lot of topics in the further slides. So I will be talking more on sodium hypochlorite, EDTA and citric acid, chlorhexidine diclofenac, certain combination products, and other irrigating solutions. So what is sodium hypochlorite? Sodium hypochlorite can be said as the most popular irrigating solution in the world. It has been in used since the Second World War as the famous material for cleaning up the wounds. But since then, it has been used in endodontics also. And what happens is it has got when sodium hypochlorite comes in contact with water, it divides into a sodium ion and a hypochlorous ion. So hypochlorous ion is usually at a pH of 9, and the available solution is usually at a pH of 12 to 13. So what happens is this hypochlorous acid, what it does, it disturbs the vital tissues of a microbial cell wall, and that leads to cell death. The hypochlorous part acts onto the proteins, and it coagulates them and converts them into amino acids. So this is the actual cause of its activity. The concentrations that are available in dentistry are 0.5% solution, and very popularly known as Daikin solution, to the latest 6% solution that has been popular after 2010. So potent antimicrobial agent, and the most active tissue dissolving property is the best part of sodium hypochlorite as a irrigating solution. What happens is when you increase the temperature of the solution, something around 60 or 70 degrees, and just like a cup of coffee, if you increase the level of solution temperature, so the activity increases. It speeds up the activity of the sodium hypochlorite. Also, the larger volume, if it is used, it helps in the better activity. It also affects the organic part of the smear layer, and Continuous irrigation with larger volumes and better contact time improves the effectiveness of the solution. Higher concentrations are always more effective, as we know, because more chlorine will be available for tissue dissolving activity. The disadvantages that are the most popular disadvantages, and it can be the reason for certain practitioners shying away from using sodium hypochlorite, is its unpleasant taste. Also, it comes with its own toxicity, and just in case it slips out into the periapical tissue, it can definitely cause a lot of inflammation, a lot of pain to the patient. Its inability to remove smear layer is also very very important. So it has been seen that the longer term of exposure can have detrimental effect on the dentine elasticity, and it reduces the flexural strength. Coming to the next topic, it's EDTA and citric acid. These are also very popular irrigation solutions. What EDTA does is, and citric acid does, they are the chelating agents. So they help in dissolving the inorganic material, including the hydroxyapatite. No antibacterial activity is there, and that is the biggest disadvantage these materials can have. These are available as gels and liquid form in buffered solutions. So EDTA is commonly used in 17% concentration, and citric acid is used as 10% concentration in dentistry. Even 20% concentration and 40% concentrations are available for frequent users in dentistry by certain manufacturers. So what happens is, when we should use EDTA? After the instrumentation is over, when your irrigation with sodium hypochlorite is over, EDTA or citric acid is used. So what happens is, whatever the smear layer or the debris has been produced by the instrumentation, and the organic part of the entire debris will be removed by sodium hypochlorite. It will be dissolved by that. But these smear layers and these debris also contain some inorganic part. So these inorganic part needs to be removed completely for effective treatment. So EDTA or citric acid, when it comes in contact, it removes the entire inorganic part of the smear layer. What happens is, when these EDTA or citric acid, they act, and it acts on the deeper part of the dentinal layers, that provides better results, because most of the antibacterial materials, or if you're using intracanal medicaments, they will have access to the deeper parts of the dentinal layer. Coming to the next best irrigating solution is chlorhexidine digluconate. Why it is popular? Because it has got good, and I must say very good, disinfection properties. It has been also the most researched irrigant solution in the recent times. So the commonly used concentration is 2%, and the advantages of sodium hypochlorite over the advantages over sodium hypochlorite of chlorhexidine digluconate is, it has got no smell, no bad smell, and it does not irritate the periapical tissue. Even if it goes accidentally there, it does not irritate it that bad. It is, I must say, it is much safer to use. And the only disadvantage that chlorhexidine comes with is it has no tissue dissolving property. So why chlorhexidine digluconate? Why it is so popular? Actually, what happens is, the antibacterial property that is provided by chlorhexidine is due to it permeates into the outer cell membrane and causes coagulation of intercellular components. The property of chlorhexidine, by what it is famous, is substantiality. Substantiality means it provides a continued antimicrobial effect by binding into the hard tissue. So whatever bacterial toxins are left inside the dentinal tubules, even after the instrumentation is over, irrigation is over, it stays back there, and it continuously provides more activity on those toxins. So it acts like a reservoir of antibiotics. or an antimicrobial activity. It does not cause erosion of dentine like sodium hypochlorite as a final as a final rinse. After the EDTA is used, it has been observed that when sodium hypochlorite is used after the EDTA has been completely cleansed off from the canals for inorganic debris removal, sodium hypochlorite can cause certain amount of erosion of dentinal tubules or the deeper sections of dentine. So chlorhexidine does not provide such erosion. It is suggested that after the entire chemomechanical process is over, we should use chlorhexidine as the final irrigant. Other irrigating solutions that are commonly used as sterile water and physiologic saline. The problem with sterile water and physiologic saline is that if the bottle or the container has been opened and is open to the air of the operator, it can actually be contaminated, and it can further contaminate the properly cleaned or instrumented root canal. So it has to be avoided for any usage in dentistry. Hydrogen peroxide is a very popular irrigant and is used in combination with sodium hypochlorite. It provides more effervescence or more bubbling action to the sodium hypochlorite activation. But when the research was done, and it was seen that if sodium hypochlorite is used alone, it produces better results when in combination with sodium hypochlorite and hydrogen peroxide. So sodium hypochlorite is alone enough to produce the desired results of an irrigating solution. Lignocaine and urea peroxide have been used in the past, but are not used as irrigating solutions anymore. Iodine compounds like iodine potassium iodide are also very effective as antibacterial materials or irrigant solutions. They come with two disadvantages. One, discoloration of the hard tissue. Second, they also can be allergic to certain patients. So if the patient is known allergic to iodine compounds, it should not be used. So what happens when these irrigating solutions are mixed together? Because a certain amount of properties are available with sodium hypochlorite, certain properties are available with EDTA, certain properties are available with calcium hydroxide. So there is a need to what we say, a curiosity to add certain amount of irrigants, and we feel that we can use them. But yes, they come with their certain interactions, and we should know about them. So what happens when sodium hypochlorite or EDTA are mixed? When sodium hypochlorite comes in contact with EDTA, it actually reduces the amount of chlorine that is available for the tissue dissolving property. And when that happens, the overall activity of the sodium hypochlorite reduces. So one of the major reasons is not to use sodium hypochlorite and EDTA as a common solution. Yes, one of the experimental materials was Trinitol X100 that was made by adding sodium hypochlorite and EDTA in a certain combination, and it is also known as endodontic cocktail, but it has not proven its results. Calcium hydroxide, sodium hypochlorite, when mixed with chlorhexidine gluconate, it actually produces a brown orangish precipitate, as you can see here. As you can see here, there is an orange precipitate. Orange precipitate that is available here, and it has been found with the spectrophotometry that this can contain parachloroaniline, and that can be mutagenic. So the usage of this combination is avoided. Also, when EDTA is mixed with chlorhexidine, it produces a white foggy material, and it precipitates during the use. So it cannot be completely removed from the canals when it is once it is produced. So the combination has to be avoided. So what should be done to enhance the activity of the available irrigant solutions? There is something called as surface activators, or what we say, these materials have an inherent property of wetting the canals, but they have higher surface uh, tension energies. So what happens is when these detergents are added, or we say surface active agents are added, the wettability of the entire canal increases tremendously and manifolds. When it increases, the efficacy of the available irrigant solution increases beautifully. So we have three very popular products out here on the screen. Smear Clear. It is one of the products that has EDTA with surface active agents, and it proves to be much more better than the available EDTA of 17%, because it clears the deeper parts of the dentinal tubules. Chlor Extra also has certain amount of surface active agents. This is 6% sodium hypochlorite. So when it was used in vivo studies, it has been seen that it clears larger amount of the activity is the larger amount of pulp tissue was removed at a very faster pace. The speed of the activity was increased. Coming to Chlorhex Plus or CHX Plus that we see, it also has certain amount of surface active agents, and it was proven in certain in vitro studies with dentinal debris blocks and biofilm products that it clears out larger amount of biofilm, or it penetrates or removes the plectonic bacteria faster. The other combination that is available commercially is MTAD, or it's a mixture of tetracycline, citric acid, and a detergent. Another product is tetracline. Both are doxycycline based irrigants. The only problem with these products is they can actually stain the hard tissue. Nonetheless, tetracline has been a better product than MTAD and proven antibacterial properties, even better than chlorhexidine. So, what are the common challenges that we face during irrigation? The formation of smear layer. The smear layer, when instrumentation happens in the root canal, the rotary instruments produce a certain amount of smear layer that can be from 1 micron to 5 micron thick. So these smear layer cannot be alone treated with one irrigant. The right combination of sodium hypochlorite to remove the organic part of the irrigation of the smear layer, organic part of the smear layer, and inorganic part of the smear layer is removed by the EDTA. And sequential use is important. If you don't use these two materials, smear layer will never be reduced. If it is not reduced, it can hamper the actual adaptation of obturation material. Dentine erosion is also a very significant thing that is under consideration now in research. What happens is when the EDTA has been used and inorganic material from the smear layer has been removed, the next rinse material is sodium hypochlorite. When sodium hypochlorite comes in contact with the remaining smear layer, it goes deeper part and removes a larger amount of dentine. So the researchers name it as dentine erosion. It is still unclear that dentine erosion is a beneficial part because it helps in cementation of post better, or it is harmful because it weakens the tooth structure. So still research is required, more research is required and of need of the hour. So the cleaning of uninstrumented areas, parts of the root canal system like fins and other areas, ramifications and isthmuses, only solution, sodium hypochlorite or EDTA or chlorhexidine cannot do it. they have to be combined with certain amount of agitation or ultrasonics so that these materials can be pushed into that areas, and the areas that are not being touched by the instrument can be rinsed off or cleaned properly. Yes, and the hot topic for endodontics today is biofilms. Yes, they are of concern because in instrumented areas or in uninstrumented areas, biofilms are present. So these biofilms need antibacterial materials, antibacterial irrigating materials. So what happens is biofilms are removed by, firstly by instrumentation, then secondly by good amount of sodium hypochlorite that is used, and third we have to make sure that they are completely disinfected by the use of chlorhexidine digluconate. Last but not the least is safety versus effectiveness in apical root canal. What happens is when these surface active agents are added to these irrigating solutions, or when irrational use of certain instruments are done in the root canal, and the material is the sodium hypochlorite, when it is added to the root canal for irrigation purposes, it can actually slip into the periapical area. It can escape into the periapical area. It can actually cause a lot of pain to the patient. So the concern is there should not be any mindless use of any material or irrigating solution. When the irrigating solution has to be used, it has to be used very proficient, with very lot of professionalism and with lot of safety measures. Anything that causes hurt to a patient is not recommended. Let me come on to the irrigation techniques and devices. So we can majorly divide them into manual or machine assisted. Coming to the manual, we can divide furtherly into syringes that are used for irrigation with the help of needles. Certain brushes are available, and manual dynamic agitation. Also, the machine assisted have rotary brushes, continuous irrigation during instrumentation, sonic, ultrasonic, and pressure alteration devices. So, since it is one of the most used or most convenient form of irrigation, syringes with irrigation, syringes with irrigant material with certain needles like endodontic needles are commonly used by general practitioners and endodontists also. So the common way of using them is the needle is bent, the material is transferred into the canal, and it is received back on a gauze piece. But it has been observed that these needles do not reach even the apical 1/3. They stay mostly in middle 1/3 or coronal 1/3 of the canal. Using specific needles for endodontic irrigation, like side-vented needles, can actually reach up to the apical 1/3 of the root canal system and provide better irrigation. Why? Because these the regular syringes or syringes with needles that we are using, they have a limited property. The material that is relieved from them or released, the irrigation material that is released from their tip can reach only next 1 mm in the surface area, in the apical area, or maybe in the direction that they have been used. So only next 1 mm is involved, and rest of the area is untouched. Also, these needles are not for actual endodontic purpose, because they can engage into the canal actively and can cause the protrusion of the irrigating solutions like sodium hypochlorite periapically and can hurt the patient majorly. So what should be done? There are specific needles that are called side-vented needles. They come in 24 gauge, 27 gauge, and 30 gauge. They can be precisely used in the apical 1/3 because of the side venting of the irrigation, they do not actually hurt the peri-apex. The material is not loaded there. They actually reach the apex passively. They go there, and the best part is the operator can control the amount of material that has been introduced into the canal. And slight moving up and down of these syringes also causes a lot of agitation of the irrigating material and helps in better irrigation of the system. So the best, how to improve if you're using needles and if you're not using other materials or other active techniques for irrigation, what you should do is, what you should make sure is lot of sodium hypochlorite or lot of irrigating material has to be used. That means larger volume has to be used. What you have to do is make sure your needle reaches at least in the apical 1/3, and the temperature of sodium hypochlorite has been increased. If you take care of these three things, I assure you, you will get better results from irrigation. Better removal of debris can be seen. So coming to the other part of the manual agitation, there is manual part. There are brushes. There are certain brushes that are available for manual use. They are called as Navy Tip FX. That is a tip with micro brushes on it, and while delivery of the irrigation into the canal, that can be pumped up and down. So the logic behind developing such product was that the micro brushes that are available over the irrigation tip will scrub the canal walls and will help in removal of the layer of any material that is available or any debris that is available. They can actually reach into the fin part also, or small misses, they can reach there and clean them up. These fibers are radiolucent, so just in case they are broken up, we will not be able to see them in the canal and will not be able to remove them from the canal. Another product is Endo Brush. This is also a good product, but the size of the actual product was bigger. So the canals that are actually apical size of 35, these can be used. So if the actual purpose of irrigation is to clean all the areas of root canal, that is apical, middle and coronal 1/3, and if we use these brushes can only be used in the coronal middle 1/3. So the efficacy is not proven, and we are still waiting for better products from the same company. Coming to manual dynamic agitation, it is one of the most popular methods right now. You can see on different social networks and platforms. What happens is the canal is prepared, and when the sodium hypochlorite is placed into the canals, the master apical size of the canal is seen, and the same size of tight fitting GP is taken. That let's say, for example, if a canal is prepared with 30 size and 6% taper, so a GP point of 30 size 6% taper will be taken of the corresponding to the last file that has been used in the canal, and sodium hypochlorite is placed into the canal, and it is vigorously pumped into the canal till the apex. So usually it is seen that up to 100 strokes can be created in a minute. That creates around 3.3 kilohertz of vibrations, and what it causes is there is always a fresh irrigating solution that reaches the apex, and the next material is pumped out. So by the rule of Archimedes principle, when the material is pushed, it goes into the finer areas like fins and the isthmuses, because the major area is taken up by the GP point, and the remaining area, the irrigating solution is pumped into those ramifications like a piston. So the GP point acts like a piston and pushes the irrigating material into those finer areas. It has been proven as a very effective method. The only disadvantage is it is very laborious. Imagine you are pumping one GP point for 100 times into each canal. So that is the only disadvantage that comes with this. Rest, it has been proven to be a very good method of manual agitation. Coming to machine assisted agitation, we do have rotary brushes. One of the product was Riddle's brush, or Riddle introduced this brush in 2001. So it rotates at 300 RPM, and it also cleans or scrubs the walls along with the irrigation material. Similar material or equipment from Colteen was introduced, that by the name of Canal brush. It rotates at 600 RPM. These both products have been very promising, and we look forward to see these products very commercially successful in future. Coming to continuous irrigation during instrumentation, what we have seen is we should know more about vapor lock concept now. What is a vapor lock concept? When there is a fine micro tubule that is available, or a micro size of pipe is available, or a column of water is available, there is always certain amount of air that is trapped in. So what happens is, it does not allow, imagine the same concept inside a apical, in a apical area of a root canal. What happens is, when you load the entire canal with sodium hypochlorite, there is certain amount of air that blocks the entire contact of sodium hypochlorite with all walls of the root canal. So this, what happens is, if you break these small air bubbles, we will have more effective activity of the irrigant. So all these machine assisted products actually focus on this concept. Coming to my favorite, Endoactivator. It is one of the sonic products that are very famous in endodontics. It has got 3 speeds. It has got 3 kind of tips, yellow, blue, and red. These are different tip sizes of 15, 25, and 30. So what happens is, you have amplification of around 10,000 cycles per minute in the canal, and it actively changes the fresh solution inside the canal. So it agitates it very nicely. The kilohertz are 1 to 6 kilohertz. What has been written in the text, it is 1 to 6 kilohertz. It reduces the shear effect of the it reduces the shear effect of the folding part of fluid dynamics. So when Endoactivator is inserted into a root canal shape you can see so much of bubble formation is there. That means it adds to the bubble part, or the agitation helps in removal of more debris from the canal system. Let us have a look at how this Endoactivator works. You can see so much of bubbling action is happening, and this Endoactivator tip is pushing all the liquid into the finer parts of the canal system. See, you can see the lateral canals are completely filled up with the irrigating solution. The best part of Endoactivator is it comes with plastic tips. So these are non-cutting tips, or they are very smooth tips. So they do not hurt the canal preparation that you have already done. Also, the disadvantage that has been proposed, but it has not been seen. It has been proposed that if these plastic tips have broke during the treatment, they cannot be removed easily. This very small problem can be treated in future very promptly by any of the manufacturers, that the polymer material that is used for production of these tips can be made radiolucent or radio opaque. Forgive me, radio opaque. Another product that has been used on the same principle of sonic irrigation is MM1500. It is from Medident. So this product is also very famous. There are Sonic files that are used, uh, and it produces the same kind of agitation with the root canal system. The only problem with this system is that the files that are used with MM1500 are like barb brooch. These files can cause, they are made of stainless steel, and they can actually cause the what we say damage to the prepared tooth structure. If because they're very sharp in nature, they can cause inadvertent problems in the canal that has been prepared. So coming to ultrasonics, there are two types of ultrasonics: simultaneous ultrasonic instrumentation and irrigation, and passive ultrasonic irrigation, that is without simultaneous instrumentation. In simultaneous ultrasonic instrumentation and irrigation systems, there's a very famous system with the name of self-adjusting files. They mostly come with the same concept, that the ultrasonic instrumentation is happening and the irrigation is happening simultaneously. They have been proven to be very good, and the results have been very promising. But what happens is, when such amount of instrumentation and irrigation is happening simultaneously, there is a possibility of damage to the instrument that has been used, because the visibility is reduced many folds. The passive ultrasonic irrigation technique, what happens is, the preparation is over and the irrigant is loaded into the canal, and then passive irrigation ultrasonics are provided to it. The product is Endostar. There are ultrasonic files that are available for irrigation purposes only. If they are non-cutting in nature, they are one of the best products. Ultrasonics are considered from 25 to 30 kilohertz range, and if ultrasonics are used with a lot of precaution, they are the ultimate products to be used as uh, providing providing the best of the irrigation devices. Coming to pressure alteration devices, there is a new system, or what we say gentle wave. It has been very promising in past 1.5 years. It is commercially available now. When the parent article of this webinar was seen, it was still in the research, but now we can see actual practical use of this system. What happens is, there is a pressure alteration device inside the knob. What it does, it does not instrument the canal. There is only exchange of the irrigation material, and irrigation material exchanges at least 100 times in 1 minute. So what happens is, there is actually no instrumentation, or NIT, or no instrumentation technique. It's popularly known as no instrumentation technique. So the entire necrotic material is removed, all the bacteria are removed, there is no formation of any dentinal chips additionally, and these can be obturated very, very easily. The canals that are prepared by this system. Another very famous system is Endo Vac system. It comes with a micro cannula and a macro cannula. So what happens is, in other systems, what we do is, we leave sodium hypochlorite or other irrigating material into the apical 1/3, and then we push them back, or there's a possibility of slippage of the material beyond the apex. But in this Endo Vac system, definitely nothing will happen. It is the micro cannula is around range of 35 number ISO file. So what happens is, it stays in the apical 1/3. As you can see in the next picture, sodium hypochlorite is filled up in the chamber, in the pulp chamber. The needle reaches into the apical 1/3, and it sucks back all the material. So there's a negative pressure that happens. It cleanses away all the debris that is produced, and safely takes away all the hypochlorite from there. So this is a very promising material that we can see in future. More research is required for Endo Vac to prove its vitality, as the material of or the device of the future. The only disadvantage that has been written in the article is um, the bigger size of the cannula. If a smaller size of cannula can be produced or it can be used in thin canals, it will be of great help. Let's hope for the best in the future for this system. So I must provide my concluding remarks for this. I must provide my concluding remarks for this study, that the need of the hour is we need more well-controlled studies with standardized dentine debris and microbial film models, so that all these materials can be substantiated and can be equally tested. Also, the effect of the irrigation material and the irrigation device has to be correlated with the actual treatment outcomes. If there is no efficacy that can enhance the treatment outcome, we cannot evaluate its actual value of actual usage in the dentistry. From my perspective of practice management, the practicality of using a material, that means if the irrigating material is very expensive and enhances the treatment cost in many folds. And so in developing countries, it is difficult to economize the entire treatment. Then if the equipment is very expensive, it becomes difficult to buy that product. Also, the ease of use and handling of the instrument and the irrigating material has to be seen. The economy of the product actually becomes a major reason for using it or not using it during the treatment. The food for thought for the upcoming or fresh researchers is how to improve the designs of the actual available equipments right now and the user friendliness that can be added to these equipments. I wish the best for all the viewers that have actually seen this webinar, and thank you for your time and your willingness to expand your abilities. I'm very grateful to you that you have beared with me for almost 25-30 minutes. I would suggest at the end of the webinar, I would suggest certain readings. There's an article from Lisha Gu, and in 2009 has to be read. It's a classic article. There's a chapter on irrigation in endodontics by Marcus Haposolo in Dental Clinics of North America. It's a must read, and most of the material that has been taken during this webinar is inspired from these two articles and the chapters. For any endodontics or any general practitioner, Stephen Cohen still remains the Bible for study. My source of inspiration for this webinar is Professor Perimashtu. I have been with him in 2017. I was with him, and we had a great time together as a training program. He told to me that it's very easy to complicate simple things and vice versa. That means as an educator, we should always simplify the difficult or the complex concepts, and we should render it or pass them on to the next generation or the fraternity that we survive in. So my best wishes for everybody who has been part of this webinar. I must thank you all. A deep thank you, or from the deepest part of my heart, to Dr. Shihab Romid. He is the director of London Dental Academy, because he is the only one who inspired me to make this webinar and explore the potential of a webinar. Thank you so much. Thank you so much. So the last word from this webinar is knowledge isn't powerful until it is applied. So hope this presentation